to go with what was there. A good few years ago, 10, 15 years ago, I was at NICE and we did a guideline on safe nurse staffing. And I drew upon that experience to a certain extent, because when you're looking at how many nurses do you need on a ward to ensure that patients are safe, there was also no literature. It was really poor. And we actually relied on data that had been collected on a notepad by a very enthusiastic senior manager who'd collected some data for us. Staffing levels don't seem to be very well researched, is the bottom line. And I would like someone to take that message away and to think about how should we collect data. It's partly why I put the recommendations in there about safety monitoring, not to be about monitoring individual people at all, but to be monitoring what's going on in the system, so that there's a bit of a red flag that says, hey, something's not right. We've got more events going on in this trust than there should be. I don't know if your experience is any different, if you think that I should have found something.
No, I just think that with all the variables that could impact that, it's difficult to say this lack of data doesn't support PA as a profession. I think that the lack of poor data, or the lack that directly points to say these are errors PAs make all the time, would be a different scenario. But that just popped out at me because the evidence was weak, but it seemed to be weak in support of the profession.
So we have an online
You're right. You
question.
are right. That was
So one of the online questions, Jill, is job descriptions were written for PAs which are beneath their qualifying scope of practice and also outside the scope of the review. Who decided that these should be written? Who wrote these? What documents were used to inform the writing of these? And who was consulted on writing them?
The job descriptions were based upon information that was widely available around particularly from the colleges, and a number of our Royal Colleges had done pieces of work already that I drew upon. So the Royal College of Physicians, College of GPs, Royal College of Anaesthetists, they've done work, and that was the basis of what should be in those job descriptions. And NHS England, who has the overall responsibility for the NHS, they took a look at them, and some people who've been involved in the work of developing the plans in the colleges also. But they are only recommendations. It's important to say that. I think it's really important that there is a national job description. It will just make it clear for everyone. Nothing in that report is set in stone. I think that's important to say, because in terms of implementation, there's nothing to say that it can't be amended if I got it wrong, because I didn't have very long. I think it's important to say that. The important bit is to have one. If it needs amending, then fine.
Thanks, Jill. There's a question here and then a question there. So I'm going to get my steps in again today, unless somebody younger wants to do this.
Yes. Professor Gillian from Uganda. So thank you very much for what you call a difficult task. There's nothing difficult there. Because always facts and science speaks for itself. My question really relates on what the lady said. If you're given a job description, if you're given the scope of practice, and this is evidenced by the skills and the competence of training, how then does the evidence become weak? Because you have a standard. The training institutions are saying the people who have trained have the skills and the competence to do the following. You wouldn't change the standard and assess them where they are and where they are not. You would assess them based on the scope of practice, the skills and competences. That must form the basis of their scope of practice. So the assessment that brings us information that's not clear what they are able to do, is negated by first principles of research, that we did not respect our own guideline. I am training physician associates, and I know that I am using a competency-based approach. And the competence is supposed to be provision of a certain scope of service. I should be assessed on that. Effectiveness, efficiency measures are all issues that can just not be assessed on an individual because they are categorical variables in the production of services and management of care. So we probably need to be looking at this before we so much publicize these uncertain findings that tend to relate. Because in Africa, for example, 80% of the services in the rural setting, where there are 80% of the population, are manned by physician associates. So we need to be able to analyze probably disparity in the gaps is because of the country's levels of development. But we ought to be able to know whether the country is developed or not, a physician associate trained with certain skills and competencies is able to deliver for that. All assessment must rotate around that and should then be able to have and say, okay, this will go. But I also want to say that I think there's a phobia I thought this is not in I thought this is in third world countries only, that the MBCHB graduates don't want to have a qualification of any person closer to that ISAMI chair.
Thank you.
Yeah, do I want to to go back to the aim of the recommendations are to give initial job descriptions and then the opportunity to develop and to do things, I think, in line with what you were saying about expanding your scope so that you are able to do new things, additional things, and train and develop and improve, and you'll have a career path that is flexible as that moves forward. It's an interesting point about what are you trained to do at the beginning, because most professions in healthcare, medicine, nursing, medicine, you study everything. You study all the different specialties. But when you first start working, you do a very narrow role. And I don't think anybody would think that just because you've studied psychiatry for 4 weeks as a student, you should be able to go and work in psychiatry. It's having the breadth of training, sure, but then you need to actually work and to develop your portfolio and your skills and your competence, exactly as you said.
Good. One more question online and then I'll come to you. So, okay. This is a contentious one, Jill.
Oh, okay, good.
So, one of the questions that are online is, why, if only doctors can diagnose and treat patients, is there not recommendations for all other professional groups to be reviewed who diagnose and treat patients?
I didn't say that. I didn't say that. Only doctors can diagnose and treat patients. So I don't think I want to answer that question, because that's not what the review says. And if people are using the review to translate to that, then they haven't read it properly.
Thank you. You do realise I'm only reading the
Yes,
online.
I do.
Right. So there's a lot of hands have gone up. So we'll go here, and then Gemma, you, and then we'll come over here. Okay, here we go. Try and keep your questions brief so that we can get through, because we've only literally got 7 minutes left.
Thank you, and thank you for your presentation. I think my particular concern, and picking it from where Professor Gillian left, is that I'm concerned that it was inconclusive. But then, though it was inconclusive, we are going ahead to take steps, and now NHS is going to take definitive steps using the SIM. My feeling was that this was the initial study and it was confined probably to the UK. But we have analogs. We have analogs across the globe, and they have a particular mandate, they have a job description, and you can be able to do a broader study that will involve the analogs, and probably that is going to inform better, because elsewhere the roles are very clearly defined, and you can be able to see how to bring in the role clarification and the complementarity that you're talking about, because in other settings that is working very well. And of course we understand the tensions between the MDs and the PAs, and they'll always be there. They're there in Africa. But then as the government and regulators, they must be able to go beyond that and above that and look at the patient and see how do they complement to ensure that we get quality. Thank you.
I could have said, the evidence is inconclusive. We need to wait another 5 years to get that research. I actually wrote in the report somewhere, now is not the time to be indecisive, to wait for the perfect research, because research is never perfect. It's never perfect. Just to give you an example, NICE had to do a guideline on preoperative tests. So what tests should you have before an operation? Zero research, believe it or not. Think of all the operations that happen every day, and nobody done any research into what should you do before somebody has one. So the best you had to do was to draw upon expert opinions, because you couldn't leave the NHS with no advice, having said we'd do a guideline. And that's exactly what I had to do. That's why I said, let's look at the broader perspective. Let's provide some clarity. I really think if I'd said, oh, I don't know, we just had to carry on and wait for research, the system, it would have got worse. It would have got worse. And what I've tried to do is provide clarity, to provide career progression, and to help both patients see that, have that clarity, but also the PA, the PAs themselves. You as a profession, I really wanted to provide that clarity. It needs some further work, but I see it as an opportunity. I genuinely do. It's not been about trying to put you in a box. It's just moving forwards constructively and making it work for everyone.